Hello, everyone, and welcome to the Radiology Cardiothoracic Imaging podcast. My name is Sonia Barra, and I'm the editor-in-chief of the journal Radiology Cardiothoracic Imaging. The host of our podcast is Praveen Ranganath from Dallas, Texas.
Hey, Dr. Ibarra. Hello, everyone.
Hi, Praveen. In this series of podcasts, we will break down recent articles and trending topics from the journal through conversations with the authors, the editors, and experts in the field. For all of you out there interested in cardiothoracic imaging, subscribe and listen to the podcast to keep up to date with recent developments in cardiothoracic imaging.
Hello and welcome back, everyone. Praveen Ranganath here with another episode of the Radiology Cardiothoracic Imaging Journal podcast. On today's episode, we will go over a recently published review in the journal focused on a hot topic both inside and outside of the medical field: COVID vaccine-related myocarditis. The title of the featured review is as follows: Cardiac MRI Assessment of Non-Ischemic Myocardial Inflammation, State-of-the-Art Review, and Update on Myocarditis Associated with COVID-19 Vaccination. This review comes to us from our colleagues in Toronto, Canada. The senior author is Dr. Kate Hanneman. This review intends to synthesize what we currently know on the incidence, pathophysiology, clinical course, and imaging features of vaccine-related myocarditis. As noted in the title, there is a specific focus on cardiac MRI and its relation to the diagnosis of vaccine-related myocarditis. To help dissect the review, I had the opportunity to speak with the study's senior author, Dr. Kate Hanneman. Let's jump into that conversation now. All right, welcome back, listeners. I am now joined by the senior author of our featured paper, Dr. Kate Hanneman. Kate, thank you for coming on board.
Thanks so much for having me today.
Of course. Before we begin, why don't you start by telling us a bit about yourself? Where did you train? Where are you currently? And what are your academic areas of interest?
Wonderful. Well, I'm a Canadian. I did my medical school and residency at the University of Toronto. I did my cardiovascular imaging fellowship at Stanford University, and then a master's of public health in epidemiology at Harvard. I'm currently appointed as an associate professor at the University of Toronto. I'm a clinician scientist at the Toronto General Hospital Research Institute, and I'm the director of cardiac imaging research for my group. Most of my clinical work focuses on cardiac MRI and cardiac CT, and I have an active research program that mostly focuses on improving health outcomes for patients with cardiomyopathies using cardiac imaging.
Excellent. Well, thank you very much again for joining us. Your expertise is going to be extremely valuable, particularly in the context of the review that's been recently published in the journal. I know that COVID-19 has affected all healthcare providers across the world, but out of curiosity, anecdotally, have you noticed anything in particular at your institution from the cardiac imaging perspective on COVID-19 that you'd like to share?
Yeah, we've imaged a number of patients, both shortly after COVID infection, as well as kind of in the later stages of recovery, and even many months later. And so we've imaged quite a number of patients, and certainly it's impacted both our volumes, and we've seen a spectrum of disease. I think many centers have as well. Perhaps more strikingly, we had an influx of requests for query myocarditis in the spring and into the summer regarding after vaccination. And, certainly I think a lot of this was seen at other centers as well, maybe spurned a bit by media reports and people being worried. And so this really piqued our interest in terms of studying this and looking at what was in the literature. And so that was a bit of the genesis of, why we wanted to write this review article, to look at what we knew and really the context of that in relation to myocarditis from other causes.
Excellent. I think that sets the stage very well for diving into that review now. So your review begins by discussing some of the pathophysiology behind myocarditis in general, not just specific to COVID-19 or vaccine related. That said, is it safe to use that term COVID-19 myocarditis when describing myocardial injury related to infection?
I think that's a good question, and it's a tricky answer. I think the answer is yes in some cases and no in others. So I think we know a little bit more about cardiac injury in the setting of COVID-19 than we did even 6 months ago, and I think we're continuing to learn. So I do think there's some evidence to suggest that a minority of patients with evidence of myocardial injuries, typically just detected with elevated troponin levels in the setting of COVID infection, meet criteria for myocarditis. Very few patients have endomyocardial biopsy confirmation of that. I think there's a much larger proportion of patients who have an elevated troponin level in that context of COVID infection who have injury from other causes. So we know that perhaps the virus can result in an overactive immune response, and that host immune response might result in myocardial injury from other mechanisms. And so I don't think that necessarily elevated troponin level means or is equal to myocarditis as we think about it traditionally in all cases.
Got you. And, in that same light, what about vaccine-related myocardial injury? Is it safe to describe that as vaccine-related myocarditis, or is that sort of painting with too broad a brush?
Yeah, I think this is also something we're continuing to learn about, and I realize that's a bit of a hedge answer, but I think this is an area we do need to continue to study, and that's something we stressed in our review article. We reviewed the data that we had to date. There are certainly cases of confirmed myocarditis that follow vaccination. Now, we don't have causality here. These are temporally related, and we know from fairly robust population data out of Israel, for example, that the rate of myocarditis based on a combination of clinical and blood biomarker factors is higher than the baseline rate in a small minority of patients, but very slightly higher. And so I think we have evidence to suggest that there is myocarditis that follows COVID-19 vaccination, particularly the mRNA vaccination, in a very small minority of patients.
Excellent. Okay. So then for the remainder of the podcast, I'll use vaccine-related myocarditis to refer specifically to what we just discussed. Tough to say causal, but a very strong correlation between mRNA-related vaccine and myocardial injury that we're seeing either on biomarkers or imaging or both. With regards to that, are there any predisposing factors for patients for developing vaccine-related myocarditis?
So this is something many people are investigating. Who's at risk? And I think that's a great question that would allow us to potentially, tailor the delivery of vaccines, perhaps to specific groups, or perhaps change the interval between different doses if that was shown to be related to the incidence of myocarditis. What we do know is that younger men are at slightly higher risk than other age groups and compared to younger women. So the incidence is highest in that group, although again, it's a very low rate of myocarditis that tends to follow mRNA vaccinations. But that demographic is what we know. We don't know why. There's several hypotheses. Could this be related to the hormone environment in that particular population of patients? And I think this is something we're going to continue to learn. And I hypothesize that we're going to learn more as the younger age group is now getting vaccinated. So it will be interesting to see whether that trend continues in the younger population of male children, or whether that, again, is more specific to the adolescent and young adult population that we already saw that signal in. So I think this is an area we're continuing to learn about. And I think it will be important to guide policy. So we want to know, if someone has a prior history of myocarditis in general, are they at higher risk of getting myocarditis after vaccination? And that may have important policy implications.
With regards to policy or standard operating procedures, I distinctly remember about 1 year ago dealing with a lot of younger patients, including athletes, that had developed COVID infection-related myocarditis. And there was quite a lot of a kerfuffle with regards to what to do with them in terms of managing them, in terms of holding them back from sports or other activities. I do want to touch now on any potential differences there may be in terms of incidence, severity of COVID infection-related myocarditis and vaccine-related myocarditis. Can you help compare them for us?
Yeah, and I think this is such a timely question, because as people and parents in particular of children who may now be eligible for vaccination are trying to understand the data, I think this comparison of risk of myocardial injury between COVID infection and COVID vaccination is incredibly important. One of the things we stress in our article, and I want to make sure we convey today is that the risk of myocardial injury after COVID infection is much higher than after mRNA vaccination. We have fairly robust data to suggest that. A large population study out of Israel, which published in the New England Journal of Medicine earlier this year, showed us that above and beyond baseline risk, so they compared to the age and sex matched control patients. So we know they adjusted for kind of the background rate of myocarditis that anyone may be at risk for. And they showed very conclusively that the risk of myocardial injury after COVID infection was much higher than after mRNA vaccination. So I think we do have data that can tell us that. And I think based on the balances of risks and benefits, of course, I personally believe that we should continue to be encouraging people to get vaccinated.
Okay, so my takeaway here is that yes, there is an association between COVID infection and myocardial injury, just as there is one between vaccine and myocardial injury. But the incidence and severity of disease is far worse with infection-related myocardial injury than it would be with the mRNA vaccines. Is that correct?
I believe that to be true. So there's two related things in your comment, and I think we know quite conclusively about the incidence of myocardial injury. It's higher after COVID infection compared to after vaccination. The severity that you touched on is interesting, and I think this is something we're continuing to learn about. So how do we define the severity of myocardial injury after myocarditis specifically? I think imaging plays a very important role in that. And we touch a bit on this concept of how extensive is the damage in your heart. This is something that MRI in particular can help us gauge. We have very little data on this in the myocarditis after vaccination population. But one of the things we comment on, and this is largely a qualitative assessment just based on the limited case reports we have, is that it seems that the extent of injury is relatively mild in the cases after vaccination. And so this is something I think we need to continue to study and study rigorously in terms of actually comparing myocardial injury or myocarditis from different causes in terms of looking at that extent, that quantitative extent of injury, and also how soon it resolves and what the residual effects are when we follow patients up.
Perfect. I think that dovetails very nicely into the next part of our discussion, which focuses on imaging. In your review, you discuss the various roles of different imaging modalities in diagnosing and identifying the severity of myocardial injury or myocarditis. The majority of the paper then focuses afterwards on cardiac MRI, which for us as cardiothoracic imagers is really the workhorse where we get ourselves involved with imaging myocarditis. Could we discuss the cardiac MR criteria that are often used for diagnosis of myocarditis and discuss how they had been validated in the past?
Yeah, absolutely. And I think this is so important for us as cardiac imagers to be familiar with the guidelines, which often we're going to apply the updated or revised Lake Louise criteria. So these were updated a few years ago. And one of the key changes compared to the original criteria is that parametric mapping techniques were included. I'm a big fan of those in my clinical practice and also my research program. And so I was thrilled personally to see these being included. And so the basic premise for the updated Lake Louise criteria is that you want to look for T2 criteria, evidence of myocardial edema. Often that indicates the acute component. There's increased fluid in the tissue because there's inflammation in this case. And the T1 component, or that T1 criteria, which is an indicator of myocardial injury and damage. So traditionally for T2, we had looked at T2 weighted imaging, and now we have T2 mapping to quantify that. For T1 criteria, kind of our traditional workhorse was late gadolinium enhancement or LGE, and now we can use native T1 mapping or even ECV to meet that criteria. So how the guidelines, how the Lake Louise criteria might be applied in clinical practice is if you meet both a T1 and a T2 criteria in a patient with a high pretest probability of disease. So in a patient with clinically suspected non-ischemic myocardial injury, if you have both of those criteria, then you have a high evidence that there may be non-ischemic myocardial injury. I think it's important to keep in mind two major points. These criteria were intended to be applied in patients with suspected myocardial injury. They weren't intended to be applied in an asymptomatic population for screening, for example. So that gets back to a bit of what you touched on. Athletes, for example, there was a bit of a kerfuffle, as you said, and I like that word, in terms of thinking about, should we be screening everyone after they had COVID infection before they go back to high-level athletic activity? And I personally, believe, and I think that now there have been many people that have come out and said the Lake-Louise criteria were not intended to be used as a screening tool. And so I think we now know that that's not appropriate. The second key point that I think is important is that the timing of imaging is incredibly important. So if you image someone many weeks or even a month after they had their acute episode of myocarditis, when they first started to have chest pain, you may miss the edema. So you may no longer detect that T2 signal. That doesn't mean they didn't have myocarditis. It could be related to the timing, as we talked about. And so I think you have to take those clinical factors into consideration, when you're imaging them in relation to when the acute episode started, when you're interpreting the data.
Wow, Kate, there is so much to unpackage there. Let's start with validation first. So Lake-Louise criteria, as we've discussed, does not necessarily apply to asymptomatic populations. So in symptomatic patients in whom we strongly are considering a diagnosis of myocarditis, great, we can apply it. However, from what I understand, the Lake-Louise criteria data, or the validation data for the Lake-Louise criteria, originated far before the COVID era. So do we have validation for the criteria in the post-COVID era with either infection-related myocarditis or even vaccine-related myocarditis?
That's a great question. I think everyone wants to know the answer to that. So to my knowledge, no, we don't have specific data in terms of how well do the criteria perform in this specific patient population after vaccination. I think that's important data that hopefully we will acquire over time. I think taking a step back to your question about validation, also brings up another point, like how can we actually, what's the ground truth in terms of establishing a definitive diagnosis of myocarditis? And this gets to something we talk about early on in our review article that I think is really important, is that often we think about histology as being the reference standard. And that's true in some ways. If you have a myocardial biopsy and it's positive, there's evidence of myocardial edema and inflammation and damage. There's specific criteria that can be met based on histopathology to definitively diagnose myocarditis. The challenge is that the biopsy is very much, the sensitivity rather of the biopsy is very much dependent on where they sample it. And so a negative endomyocardial biopsy can't exclude myocarditis. We know that. And so this concept of what's the reference standard for myocarditis is a little bit tricky. And in general, my center and most others don't routinely perform endomyocardial biopsy in all patients with myocarditis. It's an invasive procedure, obviously. And so in general, they're not performed unless the data that could be gleaned from that will change management. And that tends to happen in a minority of patients. So I think it's important to keep in mind that in many cases, imaging is actually, really guiding management and potentially making the diagnosis.
Yeah, I completely agree. Anecdotally, we have noticed that imaging, more specifically cardiac MRI, acts as the surrogate standard for determining whether or not a patient has myocardial edema and inflammation. Great. So in that light, we had mentioned some of the T1 and T2 related abnormalities that we often look for on MR to diagnose myocarditis by imaging. I presume, though, that there aren't any specific imaging features to suggest that this is vaccine-related myocarditis relative to myocarditis en bloc.
I agree with that statement, and that's slightly anecdotal based on our experience at our center of the patients we've imaged, but also based on the summary of the literature that we provide in our review article. So to take a step back, in our review, we included a table of any publications that included MRI imaging of suspected or confirmed myocarditis after COVID-19 vaccination that included more than one patient. So we didn't include case reports, but we did include case series. The largest case series that was included was 15 patients. So, that gives you some context that these are fairly small, rather, case series. But we summarized the case series that have been published to date. And based on that, based on this qualitative, assessment of the data that's been published in terms of MRI findings, it does appear that the pattern of injury on MR that we're seeing is very similar to other causes of myocarditis. So subepicardial LGE, often at the inferolateral wall, common location, for us to look for LGE with a corresponding abnormality on T2 imaging. So I agree very much with that statement, but I think we'll need further study where we actually are firmly comparing different groups of patients for different causes of myocarditis to, definitively say that.
Excellent. Next, I want to review a couple of clinical scenarios that I'm sure many of our cardiothoracic imagers out there have run into that might be a little more complicated than the straightforward myocarditis diagnosis. And when a patient is immediately post-vaccine and there's flagrant T1 and T2 abnormalities, the diagnosis is pretty apparent. But frequently, even I have encountered circumstances where in the pretty immediate post-vaccine phase, within the first few days, there are T1 signal abnormalities, but an absence of T2 signal abnormalities. And we're sort of left to question what it is we're dealing with. Wanted to get your insight on how you would approach a circumstance like that.
That's a tricky question. And I think, as you alluded to in the kind of lead up to the question, is, the timing is so important. So I think really making sure that you have an accurate history. When was the vaccination, the last dose, delivered in this context, and when did the patient's symptoms start, I think are incredibly important to understand or try to put in context T1 abnormalities without T2 abnormalities. That being said, I think if we were comfortable that this truly was kind of in the acute presentation, within, I would say, a week or maybe at most 2 weeks, then you really need to think about, those are challenging cases. Was this T1 abnormality present before? Is it a patient who might have other causes for that, hypertension, for example, or other potential diseases that could impact the heart? Or is this a marker of injury that has already healed, a very small area of edema that has already resolved? I think those are tricky questions. If I was approaching this clinically, I would want to correlate with the biomarkers, obviously the peak troponin level, but obviously also the troponin on the day of the scan, if that was available, so I could understand, was there a rise that has now resolved, and also correlate with the patient's symptoms. So one of the things we touch on briefly in the review article is that patients with myocarditis or suspected myocarditis after vaccination tend to have symptoms that start quite soon, within a few days after vaccination, and they often resolve very quickly. So within a week, in many cases, with complete normalization of troponin levels, again, within a week, if not within 2 weeks. And so I think the timing is critical in terms of understanding that. And I'm not sure. I think there's some cases that are very challenging when we only meet the T1 criteria.
With regards to the evolution of the clinical symptoms and in conjunction with the imaging findings, do we have an idea as to the potential lag time of some of the T1 and T2 abnormalities after clinical symptoms either improve or resolve?
I don't. We know not in this patient population, I should say, as a caveat. There is some data in the pre-COVID, pre-vaccination myocarditis patient population that showed us that the number of patients that meet Lake Louise criteria drops depending on the timing of imaging after symptom onset. I think it's actually quite elegant work that shows that if you image even 8 weeks after symptom onset, the proportion of patients that you're going to detect meeting Lake Louise criteria drops off, and it actually drops off quite nicely over time. So timing is incredibly important, but we don't know that in this patient population. I think that's something that will help us in terms of guiding our interpretation of imaging, but also in terms of understanding how soon we should be imaging these patients. And I don't know about your center, but we're always a bit crunched for MRI time. And so, in that kind of semi-urgent outpatient population, patients who don't need to be hospitalized with myocarditis, but we want to detect the edema if possible to try to make a diagnosis that this truly was an acute event. How soon do we need to fit them in our outpatient scanner? And that's $1 million question for us. So,
excellent. So I'd like to approach that long-term question now. How it is we think about follow-up imaging, or if there's any long-term complications that we should be looking out for. Prior to COVID-19 infection and prior to the advent of mRNA vaccines, we were pretty worried about patients that had any sort of myocarditis beforehand. There's a lot of different complications that they can develop, which we can go into now. Do we need to be worried about that with our infection myocarditis or even our vaccine myocarditis patients in the long run?
I think that's a good question. I think we don't have long-term data on this particular patient population, which our center and others I know are continuing to study. And hopefully in the next 6 months or year, we will have more outcomes data on these patients, but also follow-up imaging. I think it'll be interesting to see the change over time. One thing that I think is important to keep in mind is that in the acute myocarditis population, late gadolinium enhancement doesn't necessarily equal fibrosis. Sometimes I think our trainees and even us, think a bit in the context of in non-ischemic cardiomyopathies, often LGE is fibrosis, but in this acute inflammatory phase, LGE is often reflecting edema and it can improve. And certainly we've seen that. We often bring our patients back if we see acute myocarditis on MR, they will get followed up in 3 to 6 months. And you often will see, I'm sure you've seen this as well, that the extent of LGE will decrease quite dramatically. Now, sometimes certainly there's residual LGE. And so I think when you're 3 to 6 months out and patient no longer has symptoms, you can be fairly confident that that residual LGE is reflecting scarring or fibrosis. And so I think having that longitudinal follow-up can be really important in terms of understanding what the long-term sequela is. One of the things I think we should mention is that progression to a dilated cardiomyopathy phenotype and heart failure, often with reduced ejection fraction, does happen in patients after myocarditis, but it's a very small proportion. And so I think it's important to acknowledge that that is absolutely the reason that people get concerned about myocarditis is in that minority of patients. How can we prevent that from happening? How can we identify who's at risk of that? But it's a small proportion of patients. Many patients recover and either have a very small residual area of scarring and some have none.
Okay, with regards to the future then, what are you most looking forward to beyond just vaccine-related myocarditis imaging, but about COVID-19 imaging in general?
I'm really looking forward to seeing data from some of the larger studies and trials that are registered on clinicaltrials.gov. I'm sure you've seen there's a very large number of them that are registered looking at the role of cardiac imaging in patients with COVID. And I think there's some interesting data that I hope we'll see in the coming year in terms of the prognostic value of imaging in terms of predicting long-term outcomes. So beyond that acute edema that we might detect on cardiac MRI, for example, are we detecting changes that persist and that predict, who might go on to heart failure? And I think those are very important questions in terms of planning, particularly given the number of people that have been infected with COVID and may have residual symptoms. That ties into the second point that I think I'm interested in seeing the data on how do long-term symptoms in people with long COVID or persistent symptoms in patients who recover from COVID, how does that correlate with imaging findings either in the acute infectious period or later on? Is there a role for imaging in that patient population? And finally, I think it'll be interesting to see data on how does imaging and our imaging findings relate to blood biomarkers. I think this is an area that's of great interest, not just in this patient population, but how did they correlate, and is there a potential that a blood biomarker might be useful in terms of identifying patients that are at increased risk that may be useful in triaging patients for imaging, for example. So that's an area that aligns with my research interest, but I think there's growing interest in seeing what else might be available to us beyond troponin, which of course is a very good marker of myocardial injury, but doesn't tell us what the cause is.
Excellent. Kate, I think this has been a very informative discussion. Are there any last thoughts before we close?
I think we've touched on all of the key points. I guess I just want to say, I think imaging plays such an important role in this patient population, and access to imaging is, of course, one potential challenge in terms of having timely access to cardiac MRI. But I think we're going to continue to learn, what the importance is of imaging this patient population, and specifically, how soon we need to image them. So I'm interested in learning more on that.
Kate, thank you so much for joining us on the podcast. We really appreciate your time and expertise.
Thank you so much for having me. It was a pleasure.
Of course, the pleasure is all ours. And to our listeners out there, thank you very much for tuning in. If you like what you hear from us on the Radiology Cardiothoracic Imaging podcast, please rate, review, and subscribe to us. We will see you next time.